Okay, so I'm here to talk about perhaps the least, but actually a very important topic that applies to everyone in the field of cardiology, vascular surgery, cardiac surgery. So I'm glad I get the opportunity to talk to you about this today regarding access complications and trying to turn challenges into teamwork opportunities. I have no disclosures, so it's going to start off with a case. I got referred to this case for a patient that had a possible stroke. He was an 18-year-old gentleman who had a Metaport that was placed approximately 1 month ago. He had a history of testicular germinoma, the right AJ, 14 days prior. And since then, it was cleared for use. There was a chest x-ray that showed that it was fine. And they initiated chemotherapy. And with each session of chemotherapy, you would have several bouts of migraines and seizure-like activity. On exam, he had just had a well-healed incision, and he was somewhat somnolent, but otherwise neurologically intact. So this is his x-ray, okay? And as you can see, it doesn't look entirely abnormal. But you can see from the CT scan that unfortunately it's going into the wrong structure here. You can see it actually entered the vertebral artery right here and ultimately ended up in the innominate and ultimately the aortic arch. So just a brief review on intravascular complications of central venous catheterization by insertion site. This is a review and of about 3,500 patients, that had landmarks used and or ultrasound. It was a multi-center prospective randomized controlled trial, and they had about subclavian, jugular, and femoral accesses, about 850 each. And the complication rates were pretty similar, but the highest for the subclavian. And the complications that you had with the subclavian, you had pneumothorax, a little bit higher for the IJ, but the infection risk safest, but that had the highest infection rates for the femoral access. Some of the complications you can have with access, early complications, just to kind of go over this, bleeding, external and retroperitoneal. You can have distal ischemia. In some rare cases, if the wire goes too far in, you can have arrhythmias and tamponade, thoracic duct injuries, malposition, and pneumothorax, depending on where you're accessing. Delayed, you can have pseudoaneurysms and AV fistulas, infection, deep vein thrombosis, a venous stenosis, catheter malfunction, and in rare cases, when you have an indwelling catheter, migration or embolization, myocardial perforation, as well as nerve injury. So I think I put this slide up here half jokingly because I think this is kind of the feeling that we get as vascular surgeons sometimes when we're not happy to get the call, all right? It's like, is this what you cardiologists are doing? Do you just cause chaos and then blame us? I mean, but I know that's not actually the case. And I bring this up just because I think I do see this a lot in our younger trainees and our younger faculty that get really angry about this. And I think, unfortunately, this is not the situation to bring this up. If you're going to solve the problem, you're going to have to approach this in a very thoughtful, methodical, and fair way. So you always have to remember that, while this is probably perhaps the second or third complication that you're hearing about, for an access-related problem for that evening or perhaps that call weekend. This is probably the one complication that this person has had all year, perhaps in multiple years. So just kind of approach this with a little bit of grace and humility and be fair to your colleague that is enduring this problem. Some of the things that you want to do if you suspect iatrogenic arterial injury, ABCs, inspect for signs of hemorrhage at the site, and try to get a history of the size of the catheter, number of temps, exactly if you have any fluoro images, try to look at those to see whether or not the stick was low or high. This will always help the future repair going forward. Look at pulses and or Doppler signals relative also to Doppler landmarks. If you're unsure, you can get a CTA like we did. What I would recommend for these, get an IV in the contralateral arm so the venous contrast doesn't obscure what you're trying to look at, as well as fluoroscopy, especially at the initial site of puncture. Some of the things that we can do if we have to fix iatrogenic injuries caused by access, If it's in the thoracic area, lateral thoracotomy. If that involves the iliac or abdominal arteries, retroperitoneal exposure via kidney transplant incision or midline laparotomy. If we're worried about the cerebrovascular subclavian structures, you can make an oblique incision over the carotid or a supraclavicular incision. These are actually very useful because you can extend them all the way across the neck, or perhaps make a collar incision if you have to, if you're worried about bilateral injuries. And cardiac, if there's a cardiac problem, median sternotomy. I think I'm getting the hook here. So oftentimes you have a variety of tools that you can use to perhaps solve the problem. You can use this traditional surgery or a variety of endovascular means. One of the reasons why I generally prefer open repair for this is this is one of the oldest papers that looked at heparinization at the time of catheterization, and this is making Dr. Kraser laugh, so I'm wondering if he actually knows these guys. But anyways, so what happens when you insert a sheath without heparin, you actually very rapidly form perisheath hematoma, fibrin and clot, which is something that we all know now. And this is the paper that it's based on. It's based on this tiny paper of 93 diagnostic catheterizations that found that people did better with heparin or without. So, but the deal is with these, whenever you have an indwelling catheter for even just a short period of time, there's a little bit of thrombus that develops. And so what I like to do, in theory at least, is to open it and control it in an open fashion, be able to flush it. Make sure I get all that clot out. So in general, I do favor open repairs. A lot of people also think of, well, I made a mistake, but how about if I just pull it and maybe if I just hold pressure? Please don't do this. This is actually a really, this makes the problem a lot harder. At the very time, if you have the sheath in there, it's actually tamponading the bleeding or the problem at least a little bit, and it's a lot easier to then try to approach the problem in somewhat of a controlled fashion. So brief conclusions, 0.7 to 2% incidence of complications with access related. High index of suspicion is critical to an early diagnosis. I favor open for the reasons I just stated for you, but there are a variety of other tools that you can use to perhaps solve this problem. Do not pull unless you're absolutely sure, okay? And then just some take-home points, because I think this also brings up a lot of the professionalism issues that I try to communicate to our peers as well as to our trainees. So one is to be understanding of your colleagues. While as the vascular surgeon, this may be, like I said, the second or third consult that you've had for this same problem this evening, but for your colleague, this is the first one that they've had in years. So do not try to air grievances that you had with the entire cardiology service or the entire neurointerventional service or the entire interventional radiology service or what have you, whoever's poking holes in arteries, okay? It's not the time to air grievances. Do not be a bull in the china shop. Okay, two, and it's kind of related, be a calm leader. You have to be firm and fair and direct everybody and tell them what you need in order to fix the problem, but don't scream at them. This doesn't help you, okay? So you have to broaden your emotional toolbox beyond yelling, okay? You have to make sure that you're able to communicate effectively without screaming at them. So I like this quote by Eisenhower, you don't lead by hitting people over the head, that's assault, not leadership, okay? And then finally, take home point number 3, choose the most direct, effective, and perhaps boring solution. And so the reason why I say this is I think people, once they see these problems, their minds go in like 20 different directions because they're as amped up about this problem as the person that committed the problem, right? So what I would tell people, if you're trying to solve this problem, you want to solve it in the most direct, easiest, boring way possible. And I like this quote by Alex Honnold. So Alex Honnold, you guys all know Alex Honnold, free solo. He's the guy that climbed El Capitan without any equipment. And for him, he has this quote where he says, there is no adrenaline rush when I'm climbing, okay? If I get an adrenaline rush, it means that something has gone horribly wrong. And I think that's very prescient for everything that we do. So with that, I'll close. Thank you very much for your kind attention, and I'd be happy to take any questions.